For all the teachers, in theory, is it possible to create an AVF in lower limb? If the answer is affirmative, why is more common to create an AVG instead of this type of AVF? Who wants to answer? You can start, Carlo. You can start,
yes,
and then
yes. The lower limb AVF or AV graft are associated with heavy complication, with high risk of complications, many infections, or still lower arm ischemia and pain. I remember one patient with arteriovenous fistula in the lower limb. I remember that the patient have a high risk of infection repeatedly and ischemia. So I think that from surgical point of view, the intervention is more demanding, and we should have a team of vascular access before we place an arteriovenous fistula or an arteriovenous graft in the lower limb. The risk of ischemia or the infections is very high. In vascular access or graft in lower limb, we have many patients with ischemia, and after two years, only if 20% of graft are patent. The patency is too low, and infection risk is too high. For these reasons, we do not prefer AVF or graft or a native arteriovenous fistula to lower limb. It's better, in my opinion, a catheter, a tunneled catheter, and I think is so. What's your opinion, Jan and Jose?
Well, we have some patients with lower limb fistulas or grafts, and I would say they had to be carefully selected because of the infection risk, but also so the patient should understand clearly the risk of infection and to take care of the hygiene measures and so on. These are patients who have abundant upper extremity veins, and even there is usually no possibility of upper extremity graft. But I know some of them in which or in whom the lower limb fistulas work for years. But the problem is that atherosclerosis, which is quite common, is much more common in lower extremities than in the upper extremities. So this is something which limits our attempts of the legs.
Jose.
I agree with your comments. Totally agree that we have to select the patient because the patency is lower, although in some patients with surveillance you can maintain an important patency in selected patients. And I would like to add the possibility in think always when we have no possibility to make a graft in the upper arms, mainly in the context of occluded central veins, before to go to the lower limb, we have to remember that we have the hero as another possibility. The hero graft is a graft that is connected to the artery in the arm, but we have no options in the vein because we have central occluded veins. We can join it to a long stent graft. This is like a catheter that goes directly to the atrium. Then for this, you have to open the occluded central veins well with some dilators or some device that can open this trunk, like the surfacer. That sure you will hear about this in these training courses. that allows you to go from the femoral veins to the central trunks, open it, and after introduce a guide wire from the up down, and in this way to connect this graft to the atrium via catheter. It's like half graft, half catheter going through the occluded veins, and in this context you can use the lower limb graft like a last option. Okay, really see the same level. You can make the option of a graft in the groin or a hero. The question of the graft in the groin is probably taking into account the limited patency in some patients.
I agree. Yes, but in lower limb, should we prefer arteriovenous access or catheter? What is the message for the audience?
I think this is not an easy question, because if we think in the routine of the catheter like a last option, I think that the inertia should be also always taken into account to try first probably the graft and after the catheter, but always thinking that these patients are special patients and you have to individualize the option and personalize. Because in the context that we're moving from the fistula first to the patient first, this should be considered, because sometimes you say you have catheter during a long period of 5 years without problems. In some patients could be the indications, but otherwise the graft should be considered like last option, because you have probably lower complications in a general way than the catheters, but we have to individualize.
Yeah,